Good afternoon and welcome to our presentation on digestive health coming to you from Mount Sinai South Nassau. I'm very pleased to have two of our gastroenterology specialists, Dr. Firas Alani and Dr. Iman Andaleeb, as our expert panelists today. We're going to present the presentation, and then at the end of the presentation, we will be accepting questions from the audience. Please submit your questions through the Q&A icon at the bottom of your screen. There's a little icon marked Q&A. You don't want to use the chat icon because that is visible to all. And so to keep questions private, please use Q&A as your submission for questions. Thank you, and let's get started with the presentation. Thank you for being here today.
Our overall Long Island expansion of services, and we have a great new location in Belmore that our interventional gastroenterologists are practicing out of. Today we have with us Dr. Iman Andaleeb, who is our Director of Surgical Endoscopy, and Dr. Firas Alani, who is a board certified specialist in gastroenterology, as our guests here to talk about interventional gastroenterology and gastroesophageal reflux, or GERD for short, thankfully. And so we are here to talk about how Mount Sinai South Nassau is finding a way to help patients solve their GERD struggles. So let's first address GERD, exactly what it is and what causes it.
Thanks, Mark, for having us. GERD, basically, it's one of the most common digestive disorder in the U.S. It, with a prevalence of approximately 20%. With this comes economic burden and as well as adverse effect on health and quality of life. GERD, basically, it's a reflux of gastric content, whether it's acid or non-acid component into the esophagus and beyond. And that comes with symptoms and also complications. The patients usually, when they present with GERD, they have symptoms, and the symptoms is, well, like they are typical and atypical symptoms, which we will come through afterward to discuss them.
So that's great to know. And let's talk a little bit about some of those symptoms, typical and atypical, because those are important to recognize when you have the disease.
Absolutely. So typical symptoms are those patient will present with heartburn or regurgitation, and atypical symptoms, patients will usually come with abdominal pain and belching, burping. Some they will have chest pain, nausea, hoarseness, or even like chronic cough, and even this goes beyond into wheezing and asthma. These are the broad spectrum of symptoms that they can develop.
So I was one of those sufferers for about 25 years, and I can appreciate the wide range of symptoms that goes along with having GERD. So tell me, what is the difference between general gastroenterology and interventional gastroenterology when it comes to treating this? What will I get from an interventional gastroenterologist, for instance, that I would not necessarily find at a traditional gastroenterologist?
So I'm going to speak on the general part. As a general gastroenterologist, we usually manages different or many digestive disease disorders, whether it's a gastrointestinal tract or it's associated organs like liver and pancreas. And we do also diagnostic and therapeutic procedures like upper endoscopy, colonoscopy, feeding tube placement, video capsule endoscopy, and many others. That's like in general, and then when it comes to further workup and further investigation, we refer them to our advanced colleagues.
Right. So interventional GI also uses a lot of minimally invasive endoscopic techniques that are kind of alternatives to the surgical procedures for a lot of GI variety of gastrointestinal disorders. Commonly gallstones all the way to most complex gastric cancers. We do, most of these procedures that we do are invasive, minimally invasive. There are endoscopic ultrasound, ERCP, the TIF procedures that we're going to talk about. And each of these procedures represent a less invasive intervention for patients that historically require surgery. So,
very good. So let's talk just a little bit about endoscopy for some of our people who might not know exactly what endoscopy is. Tell me a little bit about what's involved in endoscopy.
Yeah, absolutely. So I usually explain it as like a tube, a fancy tube with a camera and light at the end. And I will start, I usually stand on the other end. I hold the tube and I introduce it into the mouth, then into the esophagus, which is the food pipe, and then into the stomach. And usually, like always, we go into the first part of the small intestine, which is the duodenum. That's basically the upper endoscopy, and then depends on what we find, we can do other intervention like taking biopsies, removing stuff, injecting, placing clips. Really, it depends on what's the purpose of the procedure and what we will find during that examination.
Great. So what special equipment, procedures, or expertise does the interventional and gastroenterology team at Mount Sinai South Nassau have?
Sure. So, here at Mount Sinai South Nassau, we offer a variety of cutting-edge procedures. Some of the procedures that we offer, such as endoscopic myotomy, that is a treatment for a lot of esophageal motility disorders, or endoscopic submucosal dissections that are used for cancer resections. And we also offer weight loss procedures, endoscopic weight loss procedures that can be also offered, and many others that we do, especially the TIF that we're going to talk about. But all of these procedures, we're actually one of the few centers in the United States that actually we can offer these procedures for these patients.
Excellent. So one of the things that Dr. Andali just mentioned there was esophageal motility. And I will ask him to explain exactly what you mean by esophageal motility.
Sure. So the esophagus, normally whenever you try to swallow, the esophagus starts contracting and the food basically goes down into the stomach. A lot of patients that have acid reflux symptoms, they may have other underlying diseases that can affect the motility of the esophagus. So we have a lot of tests that we can run in the hospital to basically find these underlying disorders. And we also have a lot of treatments, and then now minimally invasive treatments that, again, as I mentioned, historically it was surgery to basically treat these patients, but then now we can actually offer them endoscopic management.
Right. I know that we have some procedures that we offer, and some things that are done in office and some things that are done in the hospital. And so, but if we do these procedures in the hospital, what's the importance of having them done in a hospital versus, say, an ambulatory surgery center?
So by providing these procedures in the hospital, you can rest assured that we have all the necessary support from anesthesia, radiology, surgery, and even some other subspecialty like cardiology if that's needed. And most of the procedure that's usually we do and we offer to a patient, like elderly patient with other comorbidities. So having them do this procedure in the hospital will be more beneficial to them.
So how do you test someone for GERD?
Testing is done through first a questionnaire and talking to your provider, getting history from them. This will help us determine whether you have a really hard GERD or something else. We can do an upper endoscopy with or without biopsies. For those who elect not to have any endoscopy procedure, they can have a biome swallow test, which like they go to a radiologist, they give them contrast, and then they swallow the contrast, and the radiologist will see in that time when the contrast go into from the mouth into the esophagus and the stomach, and then we go straight back into the esophagus. The gold standard test is really pH. It's called pH monitoring devices, which is like a reflex measuring device that we attach into the esophagus, and that will help us determine how much reflux happens and whether this will correlate with the patient's symptoms or not. There are other fancier tests, and they are still under investigation, but they are showing some promises. Maybe in the near future, we can use them in diagnostic GERD.
Great. And the contrast that Dr. Albani was speaking of is a dye that is used with a radiology test to better show the interior organs so that when we're taking your radiology that we can have the best view possible while we're doing the procedure. Is GERD harmful to people in the long term?
GERD by itself is not life-threatening condition. It can be a chronic. On a long term, especially in those with poorly controlled or untreated GERD, they can develop complication from that. And to name a few, esophagitis, which comes with complication including GI bleed, and also can develop strictures, which can lead to difficulty swallowing or food getting stuck in the food pipe. Other more drastic complications, including Barrett's esophagus, which is a pre-malignant condition, which it will eventually develop into cancer. So that's why early diagnosis and early management is really required in this condition.
So is there, are there things that people can do to prevent GERD or lower the occurrence of GERD?
Oh, that's a good question. So speaking of a primary prevention, unfortunately, we don't have like a specific way to say who will develop and who will not develop GERD. People like, again, like the prevalence is like 20% in the US. So some people, we associate GERD with people who are obese, who has like sedentary lifestyle, who drinks, smokes. But other people, you'll see on the other spectrum, people who are very thin, slim, doesn't smoke or doesn't drink or doesn't do any much of the stuff that causes GERD, they still can develop GERD. So as a primary prevention, that's like almost impossible. But as a secondary prevention, which is like diagnosing and preventing early complication, that can be definitely, like we can work on that through medication, through lifestyle modification, and even procedures.
Great. And you mentioned medication. Then there are lots of medications, it seems like, over the counter as well as prescription. To control GERD, is it okay to just take those as prescribed, or are there risks for long-term exposure to the medications?
Absolutely. These are great medication that's offered for management of GERD. But again, I would always consult with the provider and find out if you have really GERD, because taking this medication can mask as dangerous or harmful condition that you have, and delaying by you taking this medication for a long period of time can hide the real condition, and subsequently you will develop complication unnecessarily. So I would definitely make sure that you have the condition and treat it as appropriate.
That's an excellent point. It's so important to get a provider's evaluation and not make these determinations on your own or by way of Dr. Google, which is what a lot of people wind up doing, because Your digestive system and gastric system are nothing to mess around with. And if, as Dr. Alani says, you're taking a medication that's for GERD, but you're masking symptoms of something else, it could cause issues in actually diagnosing you for the problem that you really have. So always take these medications, even over-the-counter medications, at the recommendation of your physician. If someone has been taking the meds for a long time without success, what are their options?
Oh, that will bring me back to the same point. Maybe you don't have GERD, maybe you have something else. So first we have to know exactly if you have GERD or not. Second, let's go over how you take your medication. Are you taking it appropriately as prescribed? Because if you're taking them, believe it or not, at a certain time of day, it's not going to be as efficacious as like what usually is recommended. And third, are you doing the lifestyle modification and the things that you're supposed to do? Are you following the real recommendation for management of GERD? And if everything is done by the book and you still have GERD, then you are labeled as a refractory. You have refractory GERD, and in that time, really, the procedures, the investigation that has to be done is more and like advanced investigation, and ultimately you might benefit from doing a procedure or surgery.
Now, Dr. Analiv, earlier you mentioned endoscopic therapeutic options for GERD. Can you expound on that? And also you had mentioned TIF, so let's get into TIF and what that stands for and what it involves.
Sure. So currently we have a lot of different options, endoscopic therapeutic options. We have injectable agents that we can inject around the valve between the stomach and the esophagus to kind of bulk it up and make it tighter. We have anti-reflux mucosectomies. We have other procedures, and as well as TIF, which is transoral incisionless fundoplication. This is what we do at Mount Sinai South Nassau. This is basically using a device to wrap the stomach around the esophagus to basically tighten the gastroesophageal valve. And that basically helps to prevent acid coming up into the esophagus and cause GERD symptoms. So
who's the potential candidate for TIF?
Right. So again, the most important thing is that all the patients who think they have acid reflux symptoms, they should be evaluated by a general gastroenterologist before seeking these interventional techniques. They should be above 18 years old. They should have GERD symptoms persistently for over a year while taking medication. And they should have the tests that Dr. Alani mentioned. They should have an actual diagnosis of acid reflux before, again, seeking these procedures. And they should also have other tests to rule out any other underlying esophageal motility disorders that I was telling you about. And also the most important thing, if they have already had an endoscopy before, they should have a hiatal hernia. That is, they should not have any hiatal hernia, or they should have a hiatal hernia less than 2 centimeters to be a candidate.
Great, great. Are there cases where TIF isn't indicated for someone?
Yes. So right now, the contraindication for TIF are the obese patients with a BMI of more than 35. Again, the most important thing is if they have a hiatal hernia that is larger than 2 centimeters, that is an absolute contraindication. If they have severe inflammation of their esophagus due to chronic acid exposure, as Dr. Alani mentioned, it can cause inflammation. So if they have a lot of inflammation, they are not a candidate at that point. They should have their inflammation improved before they seek the procedure, as well as any narrowing or a stricture in the esophagus. If they have any blockage, they can't have this done. Or if, again, I must say again that if they have any underlying esophageal motility disorders, they're not a candidate.
Okay. Is there a surgical option besides the procedural options? Is there a surgical option to reduce GERD?
Yes. So if, for example, for patients that they want to go have surgery done, again, the surgeries have been out there for a long time. There are more data on it, but it's obviously more invasive. The surgeries are called Nissen fundoplication, which is pretty much very similar to TIF procedure. It's just it's being done surgically. And patients who have a hiatal hernia that is larger than 2 centimeters are actually benefiting from a surgery procedure than the endoscopic procedure.
So with any procedure, there is a recovery period post-procedure. So what type of recovery period should people expect with the say the TIF procedure?
Sure. So again, the beauty of endoscopic techniques are these are essentially outpatient procedures. So the patient would come in the morning, get the procedure done, and they can essentially go home on the same day. And basically, the only issue with the that I always tell my patients about TIF is the diet, that you have to be on a very strict diet for 6 weeks post-procedure, and also the recommendation is not to lift more than 25 pounds for the first 2 to 3 weeks.
Great. As somebody with a 25-year history of GERD, I was grateful to learn of the interventional endoscopy program here at South Nassau and have my workup and eventually my procedure performed here. And it's a great feeling not to have the esophageal burning and the reflux at night waking me up in the middle of my sleep, which really then leads to I can't get back to sleep, and that's a sleep issue for me. And chronic cough that I had, swallowing issues. There were a whole host of things that were alleviated. Once I had the TIF procedure, I am happy that I can sleep on my side again because that was always an issue for me. But thanks to Dr. Alani and Dr. Andali for the eye-opening Q&A that they've given us today on GERD and the options and the information on Mount Sinai South Nassau's great program for interventional endoscopy. We'll now open the chat up for live questions. So if you'll use the Q&A chat balloon icon to ask those questions, that would be great. Also, I'll give you the number for the practice for Dr. Alani and Dr. Andali, which is conveniently located in new space in Belmore on Merrick Road. It's just west of Belmore Avenue at the side of the former Red Door and Mind spas. And Dr. Andali and Alani are accepting referrals and new patients, and their phone number is 516-992-5626. Again, that's 516-992-5626. And now we'll open it up for your questions. Thank you.
So the doctors have answered a lot of my questions today, but you may have questions of your own. So if you will open the Q&A icon at the bottom of your screen, and we already have a question in chat that Dr. Alani is going to answer. But if you'll open that icon, you can ask your questions there. They can be general questions. Understand that some specific questions may require an appointment with one of our specialists to accurately address your personal health circumstances because everyone is different. So let's go ahead and answer the first question that we have in the chat, which is, can you discuss silent reflux or LPR and its treatments?
Yes, so can you hear me? Okay, sorry about that. You can hear me now? Okay, wonderful. So just to answer about LPR, it stands for laryngopharyngeal reflux, in which the retrograde movement of gastric content into the not only the esophagus but also reaches the larynx and pharynx, and that by itself can cause irritation and problems to the larynx and hypopharynx area. And usually patients present with symptoms. It's not really a silent reflux, but usually patients will have upper symptoms that include dysphonia, change in their voice, hoarseness, cough, also the sensation that there is always something here in the neck stuck in my throat, they will say. And sometimes patient will say that they always have to clear their throat, and also sometimes they have difficulty swallowing. That's because all of the reflux that happens and reaches that area and causes these problems. The significance of this diagnosis really is controversial. Well, we don't know if really it's worth the diagnosis, but our ENT colleagues, they love to diagnose this, because a lot of patients, they go to ENT for a problem with the throat, and then they end up doing a fluoroscopic examination, and they diagnose them with LPR. Honestly, there is no goal, there is a lot of controversy also about the way to diagnose this condition. The best way to do with that is through a dual sensor pH probe, which is obviously not all ENTs does that, but they send them based on the symptoms and also on the findings with their endoscopic or fluoroscopic examination, fibroscopic examination, I'm sorry. And usually, the way that we manage this condition is through dietary. First thing is diet and behavior changes, lifestyle modifications. It's a really big in management of GERD and also including LPR. So we usually tell patients to avoid things that has caffeine. So avoid coffee, alcohol, chocolate, peppermint, carbonated beverage, even nicotine, like gums. They can cause all this relaxation in the upper esophageal sphincter and make the acid goes up into the larynx and the hypothyrox area. On top of that, also, we tell them to avoid any spicy food and avoid big meals, eat small portions, frequent, instead of eating like a big meal that will distend your stomach and makes the reflux goes more frequent, and also avoid any vigorous exercise after eating for at least 3 hours, and avoid laying down for 2 to 3 hours after meals. That's all lifestyle modification that can help with managing reflux and also LPR. If that fails, then we treat with medication, and we have multiple type of medication. The most powerful one is PPI, as we discussed earlier, is proton pump inhibitor, that omeprazole, pantoprazole. These medications are great, and they decrease the acid in the stomach and then decrease the amount of acid regurgitated into the mouth and the hypopharynx area. That one, and also on top of that, we can prescribe Pepsid, and if we put them usually on 6 weeks treatment, if patient responds, then that's great. We start to taper them. During this time where we give this treatment, we reinforce the lifestyle modification and diet and the exercise. And within this 6 months, if they respond, that's great. We taper it off and we stop it. And if they don't respond, then we have multiple options, and that include adding a new medication, and which usually a neuromodulator that change the perception of pain and reflux into the esophagus and how the patient feels it. Or also we do further workup that include endoscopy, just to make sure that there is no other underlying causes for them to have this bad symptoms.
Great, thank you for that very thorough answer. It was a great answer. I have another question in the Q&A, which is reflux a result of chronic constipation? Oh.
No, it's not. Chronic constipation should not cause a reflux, and it's not non-etiology of or one of the causes that lead to reflux. Maybe like a patient feels that their belly is distended and from constipation, and that causes their stomach acid to go back into their esophagus and causes the symptoms. But honestly, the answer is no. There is no correlation between chronic constipation and reflux. Chronic constipation, if it's presented, this is not normal. Also, it has to be further investigated before we decide whether it's the cause of reflux or not.
Great, thank you for that. One other question that we have is when a person starts experiencing the challenge of, say, coughing that's habitual, because the coughing that goes along with GERD is not just a cough that comes around once in a while. It's something that comes over weeks and weeks. And how can a person identify that that what they have is possibly GERD? Is that something they need to have an appointment to do?
Yes. Any chronic cough is not normal. Again, it has to be investigated. It depends on the patient age. So if a young patient or elderly, the workup is completely different. We go over the medication because there are certain medications that can cause a cough. There are certain lung conditions that can cause cough. We go over whether there is any GI complaints, any GI symptoms. If there is none, then it's unlikely to be the reflux that causes a patient to have cough. That's basically the short answer. If there's more information about the chronic cough, then maybe I can help with more explanation.
Very good. This is an excellent question as well. If I'm a patient, can I make an appointment to see either Dr. Alani or Dr. Andalib on my own, or do I have to be referred by primary care physician? So that's a great question, and one that we all discussed in advance of this. So go ahead and give that one.
Oh. So I'm going to go ahead and answer that. They can be coming to us directly. The only thing is that they should see Dr. Alani first before seeing me. As I said during the video that you guys watched, most of the patients should be managed by a general gastroenterologist to be actually diagnosed first, and then do the proper workup before they seek endoscopic management, surgical management for this type of procedure.
Perfect. Another question that was just asked is, does a person who has a lap band, can that person develop acid reflux?
Okay, so yes, a person who has lap band, they can also develop acid reflux, obviously.
All right, very good. And we have another question. I've been treated for 3 types of PPI, but it seems like nothing is working. What's the next step?
So a short answer is you have to have something called Bravo study, which is a pH monitoring device that attached into the esophagus, and that device will calculate how much acid happens and correlate with the symptoms that you have. And if and based on the result that we get from this study, we can say that you have a real reflux or minimal reflux, or you have something called hypersensitive esophagus that's managed completely different, or even functional heartburn. So not always PPI is the answer for reflux. And if you have not had any endoscopy done, before this, being on the PPI, definitely you'll need endoscopy, and then we will do more testing to rule out other disease that can cause you to fail the response to PPI.
And just so that we clarify PPI, PPI is a proton pump inhibitor, which limits the stomach's production of acid. And so that's what we're talking about when the person who's asking the question said it's been treated with 3 different types of PPI. And then, of course, Dr. Alani's answer. I don't see any other questions in the chat at this point, but I want to thank both our specialists.
I think there's another question. So yes, there are 4 general gastroenterologists plus 2 interventional gastroenterologists. So we're actually 6 people that are part of this practice.
Right. Great, thank you. So I want to thank everyone for attending today, and want to invite you again, if you'd like to make an appointment, you can call the offices of our gastroenterologists at 516-992-5626. Again, 516-992-5626. And they're located at 2750 Merrick Road in Belmore, just west of the intersection of Belmore Road and Bedford Avenue. Thank you again, and have a great evening.